So, like CBP line or arterial line, you have to hook it up to a fluid field monitoring system. It's got pressure bag, it's got transducer, and this is what is going to display the information on the oscilloscope so that you can have a readout of your blood pressure. If you have a Swan-Ganz catheter in, you'll be able to see your CVP, your PAP, your oxygen saturation if they have all of that. Okay, so that's what this is. Okay? So it says that, let's go over the, so let's go over the learning objectives. You'll be able to understand the principle of the fluid field monitoring system, how it works. Understand the components of the fluid field monitoring system. Define a transducer. Understand the relationship between the position of a transducer in relation to the level of the heart and hemodynamic pressures. You know that you have seen the IV pole. Okay, this is usually hung on the IV pole. So that transducer has to be at the level of the heart if you're going to measure normal hemodynamic pressures. Understand the effects of hydrostatic and atmospheric pressures on the hemodynamic pressures. Okay, so it says that fluid field monitoring system is an equipment used to measure and monitor hemodynamic pressures. Okay, so CVP line, arterial line, PICC line. Have you ever heard about the PICC line? PICC line is the one that they put in the, usually in the femoral artery, and it comes all the way up, enters the junction of the right atrium and the superior vena cava. Okay, they call it the PICC line. So, which is peripherally inserted cardiac catheter. So it is a CVP line, okay? So when you have the PICC line, you can use it to administer fluid. You can use it to administer hyperalimentation material like tube feeding. You can use it to draw blood if you need to, okay? So if you have the PICC line, you will also need a fluid field monitoring system, okay? Then it says that bedside monitor displays the pressures and waveforms in various components of the heart, and that is true. So once you get this end here connected to the catheter inside the blood vessel, because it's like you put in your catheter inside the blood vessel, like artery. If you're doing airline, you put in the catheter inside the artery. If you're doing CVP line, you put it inside a vein, and then it sticks out on the other hand, so you hook this up to it, and then this portion here connects to the monitor, okay, the oscilloscope, the bedside monitor. And then the transducer will transmit that signal that is sensing inside the blood vessel up here, okay? And then this causes it to display on the monitor, okay? So you're gonna see everything, all the pressures, all right? Depending on the type of intravascular catheter that you have, okay? If you only put in like the A line, you're only going to be seeing the blood pressure, arterial pressure. But if you put in a Swan-Ganz catheter, we're still gonna go over there, you see a lot of hemodynamic pressures like the ones that we went over yesterday, okay? So, monitoring physical principle of fluid field system. The monitoring physical principle of the field system states that an indwelling catheter inside the blood vessel transmits pressure through the fluid field tubing. Okay, so this is so this is a fluid field tubing. So once you get the catheter in, like I said, this portion here hooks up to the end of the catheter that is sticking out from the blood vessel. And then the electrical signal or the physiological signal that is being sensed by the tip of the catheter inside the blood vessel is then transmitted upwards, because you're gonna have normal selling in here. Okay, that's normal selling. You're gonna hang it here, okay, and then it runs down all the way down here. So that signal goes through the water or the normal selling up the hill, and then goes to the monitor. Okay, a pressure change inside the end of the tubing is equal to the pressure change inside the other end of the tubing. So whatever pressure that you have inside the catheter, inside the blood vessel, will be the same pressure in here. Okay, and that is because you cannot compress fluid. Okay, you cannot compress fluid. So that's why the pressure is always the same. Okay. A fluid medium allows the transmission of pressure from the tip of the catheter placed inside the blood vessel to the transducer. Okay, now there is something called a transducer right here. This one here. Okay, that's the transducer. Now, a transducer is a device that converts energy from one form to another. That's what it is. A transducer is a device that transforms energy from one form to another. So what's going on here is that physiological signal that is being sensed inside the blood vessel is transmitted up the tubing, and then once it gets to the transducer will transform that signal to a low voltage electrical signal. Okay, it will convert it to a low voltage electrical signal so that the monitor is able to read it. Okay, and then display numbers and then waveforms. Okay, not only will you see numbers, you can also see waveforms. Okay, so right here, this will be the catheter inside the blood vessel, right here, and then here is the tubing. We'll hook it up to the end of the catheter sticking out from the blood vessel. Okay, and then the pressure is sensed here and then transmitted upwards because you're going to have fluid in here. Gets to the transducer. Now the transducer will transform that energy to a low voltage electrical signal, and then the monitor reads that and displays information. Okay. Any questions about that? Okay, so these are the components of the fluid field system. Okay. You have the intravascular catheter, which is the catheter that goes inside the blood vessel. Okay, and the tubing that hooks up to it once you get it in there. You have pressure transducer. You must have that because that is the device that transforms that physiological signal to low voltage electrical signal so that the oscilloscope can read the numbers and draw graphs. So you have amplifier and monitor, which is actually the oscilloscope. Okay, the oscilloscope amplifies that signal. Okay, that low voltage electrical signal, it will amplify it. Okay, causing you to read those numbers. And then you have a flush system, okay? Now the flush system consists of the bag and normal saline, a bag of normal saline. Because what happens, sometimes you draw blood through here, okay? Like, this is called a stopcock, okay? The lab can come, give a syringe to the nurse to draw blood from the patient, and then they can open one of these up and draw blood from it. But what's going to happen is that when you draw blood from here, you're going to have blood inside the tubing from here to here, okay? You're not supposed to leave blood outside the body because there is increased tendency for that blood to clot. So what we do is once the blood has been drawn, you have to kind of flush it back into the body. Okay, so that's why we have the flush bag. And then another thing that the bag does is, especially if you're inside the artery, okay, the arterial pressure is about 300 millimeters of mercury, a lot of pressure inside the artery like we went over the other day. So, just like you're doing blood gas, okay, once you puncture the artery, you have that versatile flashback of blood. So the same thing here, okay? If you don't have the bag and put enough pressure in the bag to counteract the pressure inside the artery, naturally, blood will then flow out of the body, okay? So that's what we do with the bag. We put enough pressure. There is something here that you use to squeeze. It puts pressure in the bag, and then you're going to see some reading here. Okay, you want to put enough pressure to make it up to, or a little more than 300, because that's the arterial pressure, or at least greater than the patient's systolic pressure. Okay, if you don't do that, then blood will be flowing out from the body. Okay, if you put your catheter inside the vein, well, you're not going to need 300. Okay, because inside the vein we don't have a lot of pressure. The resistance is low, okay, because the vein can distend. But we need to still put enough pressure to counteract whatever pressure that is inside the vein so that blood doesn't come out from the body. So that's what the flush system does, okay? Any questions about the components of the fluid-filled system? Okay, well, let's take them one at a time now, okay? So the intravascular catheter and tubing are inserted in the blood vessel for measurement and monitoring of hemodynamic pressures. Yeah. If you want to continuously monitor a patient's blood pressure, you're going to put in an A-line, okay? And then another thing that the A-line does is if a patient is going to require frequent blood gas sampling, you can draw it from there instead of sticking the patient all the time. You draw it from there, okay? One end of the catheter dwells inside the blood vessel, and the other end is connected to a fluid-filled tubing, which connects to a pressure transducer. And you can see it there. There's the catheter, here's the tubing, and then it connects to the transducer. Any questions about the indwelling catheter? Okay. If you get ready to put in, like the respiratory therapist at Loveless can do airline. So I don't know whether there's any other hospital here that allows the respiratory therapist to do it, but you can do it. Like if you work in Florida, respiratory therapists actually put in airline and monitor and manage the airline. So it's kind of like a little different from state to state. But I know Loveless can do that, okay? And then we go to the pressure transducer. Like I said before, a transducer is a device that converts energy from one form to another. So in this case, it will convert the physiological signal that is being sensed at the tip of the catheter inside the blood vessel, okay, to low voltage electrical signal. And then you sense that information to the monitor so that the monitor can draw and display the numbers. Okay? So it's right here. And then a transducer has a pressure sensitive diaphragm. If you look in here, you're gonna see that little stuff in here. It's called the diaphragm of the transducer. So what the diaphragm does is to help measure the amount of pressure that is coming to it. So once the pressure is coming up from here, it gets to the diaphragm of the transducer. The pressure is pushing on the diaphragm like that, displacement. So the more the diaphragm is displaced, the higher the pressure. That would mean that more pressure is coming up. The less the diaphragm is pushed, the less pressure that will be read out on the monitor. Okay? So if your diaphragm is messed up, you're not going to get accurate pressure because it's not sensing the pressure very well. Okay? And then we have reusable transducer, and then we have disposable transducer. Okay, it used to be a long time ago that if a patient got discontinued from using one of these, we can use it on another patient. We sterilize it. But now they have disposable ones that once you discontinue a patient, you just dump it in dirty equipment, something, and get a new one for another patient. Okay? They are cheaper now than they used to be. So what is currently being used more is the disposable kind of transducer. Okay, all of these here will be thrown away. You are no longer using it on the patient compared to like before. Here's the monitor, the oscilloscope. Like I said, it amplifies the electrical signal, and then you're able to see these kind of things. You can hook up your EKG to it. You can hook up your blood pressure cuff to it. Then you can hook this up to it, and then it will display the pressures. Like if you have the airline, one of the lines there will be airline. If you have Swan-Ganz catheter, then you have a readout of your PAP pressure, your CVP, your wedge pressure. All of that will be shown. This is your oxygen saturation there, plethysmograph. Okay? So that's what we call it. This is an oscilloscope. It's an oscilloscope. Okay? All right. Something here to point out is that on the oscilloscope, usually what you see is two strips of EKG rhythm. Okay, two strips. Unlike if you are doing like 12 lead EKG, you're going to see more. Okay, so in the ICU, it's only two. So that will be like V5 and V2. No, V5 and lead 2. Okay, lead 2 is like this. Okay, lead 2 takes the best picture of the left heart. The left heart is more important to monitor because that's what actually gives the cardiac output that will supply oxygenated blood to organs and tissues. So we like to monitor that. And by the way, over 80% of the heart attacks will happen on the left side. Okay, so in the ICU, we are mainly monitoring the left heart. So V5, precordial lead V5, and lead 2 are used to monitor the left heart. And then that's the only thing you're going to see on the oscilloscope. Okay? Any questions about that? So, if I had airline inside the patient, then I would have a line there that would kind of look, this is what the airline looks like. Like that. So we have a line that is showing that way with blood pressure, with the blood pressure at the end of it. Okay? All right. Okay, Okay, here is the flush system. So like I said, the flush system has a bag of normal saline. Long time ago, they used a heparin, okay? They were using heparin because the heparin helps to prevent the blood from clotting, because once you get the blood out of the body, if you are drawing blood, those few seconds that is going to stay out there, something, you may develop a lot of clots. And then if you push it back into the body, then that clot will embolize. It can follow the blood flow and end up somewhere that you don't want it to end. So they were using heparin. But then later on they found out that if you are continuously flushing the line, that's more heparin getting inside the patient. And then that will overthin the patient's blood. Okay? So majority of the people now are using normal saline as the flush solution. Okay? Or if the patient has it, the patient's blood has a tendency to clot more, they can mix up a little heparin with it. Okay? So mainly it's normal saline. So we have the bag, inflatable bag. You squeeze on it right here. If I want a pressure of 300, I have to keep on squeezing on it until it reaches 300. See, there's some mark there. If I want a pressure of 50, then I don't have to squeeze that much. So once you put that normal saline inside the bag, it's usually inside the bag. As you're doing this, you're squeezing on the bag of normal saline as well. Okay, so the more pressure that you are putting on the bag of the normal saline, the higher the pressure inside the tubing, okay, and therefore it prevents the blood from coming out. Okay, so usually when nurses come around and they see that there is blood in here, okay, what they're going to do basically, they flush it first of all, and then they increase the pressure to the back, okay, so that you have enough pressure in there, okay? And then we have stopcock right here. The stopcock is where we can get blood from, okay, right here. There are three ways that you can turn this. So it can be in this position now, standing up. So if you're standing up like that, it is communicating with the bag and the patient. So basically what that means is, if it is straight, normal saline can come down from the bag, go through here, and go into the patient. So it's communicating. Now, if you turn it this way, you are cutting it off to the patient because the patient is over here. You are cutting it off to the patient. So if the normal saline comes down here, it cannot go past here because you have it cut off, and then it has to exit here. Okay? Likewise, if you turn it this way, you are cutting the system off to the bag. Okay? And you have to do that when you're drawing blood. You cut it off to the bag, you put your syringe here so that when you pull, the pressure is from here. The blood comes out and goes into the syringe. Okay? And then you have to stand it up, and then you put your cap back on. Okay, so they call it a three-way stopcock. Okay? Usually we don't sign up students on doing airline. We don't sign them up for that skill because you're going to learn how to do it once you start working. It's very easy. You know, they show you how to do it one time, you're good. Okay? All right. Flush system has two functions. It prevents blood clot from forming. Okay? We have to push the blood back into the body as quickly as possible, okay, without normal saline. And then it prevents the backflow of blood from the blood vessel. Okay. Put enough pressure there to counteract the pressure inside the artery so that the blood is not coming out. Any questions about the flush system? Okay, so this is an algorithm of how the thing works. So now you're gonna have that catheter inside the blood vessel. It senses the physiologic signal, and then it sends that to the transducer. The transducer now will amplify, okay, or convert that signal to low voltage electrical signal, and then it is sent to the amplifier and the recorder. The recorder is inside the oscilloscope, and then you have your numbers and the waveform. Okay, so accuracy of pressure measurement. We have to make sure that the pressures that we're measuring are accurate, because doctors can use those numbers to make clinical judgment. Okay, so as a respiratory therapist or nurse, you have to make sure that you're taking care of the transducer, make sure it's calibrated, make sure that it's level with the heart, so that when the doctor comes in and looks at the chart and see the patient's blood pressure or their CVP or whatever, they can actually trust that they are the right numbers, so that they're not making wrong clinical judgment. Okay, so the accuracy of pressure measurement depends on the patency of the fluid-filled system, the integrity of the transducer, and system calibration. Okay? What will determine the accuracy of the pressure that you're measuring will depend on those three things. Okay, patency of the fluid-filled system. Obstruction in the tubing causes damped waveform, okay? So it may be caused by blood clots. Now, damped waveform is nothing but abnormal waveform. Like I said, this would be the one for, if you have airline, you're gonna see things like this, okay? This is called the decorative notch. Okay? Anytime you cannulate an artery, you're going to see those things. Okay? Because they signal the closure of the aortic valve and the pulmonic valve. Okay? But now, instead of seeing this all the time, so let's say I have pressure of 130/70 per base, and then all of a sudden, I'm looking at something like this. Okay, now, I don't see the coated notch here. That's damped waveform. It's abnormal waveform. Therefore, I should not trust the blood pressure that comes with it. Okay? Anytime you have abnormal waveform, you should not trust the blood pressure that comes with it. That's wrong. Okay? So one of the things that can cause you to have abnormal waveform or damped waveform is obstruction, and that obstruction can be caused by blood clots. Okay? So blood clot can develop distal to the tip of the catheter. So you have, here's the catheter right here, and then you have a clot here. That will prevent the signal sent here from moving up the way it's supposed to move up in the tubing. And that will give you wrong waveform as well as wrong numbers. Another thing that can cause it is improper positioning of the catheter in the blood vessel. Okay? Now, once you, if this is your blood vessel, well, the catheter needs to be midline of the blood vessel. Midline. Okay? Now, things may go wrong sometimes where instead of the catheter end up being in the midline of the blood vessel, it is like that. It runs into the wall of the blood vessel. That's obstruction. Okay? And then that will cause you to have damp wet flow. Maybe the patient moves around or something. And then also, air bubble can get into the blood vessel as well and cause problems. Okay? Anytime you open the line up, you open it, the transducer, air can get in there. Okay? When you are getting ready to put in the airline or the catheter, whatever, air can get inside the blood vessel. So that will cause obstruction as well. Okay? So anytime you have that damped wet form, abnormal wet form, in order to restore that so that you can start getting normal blood pressure again, there are 3 things that you have to do. And you have to do them in this order, okay, on the test. Okay? So the first thing that we can do is we use a syringe. I'm going to put a syringe here, an empty syringe here, and then we're going to aspirate blood. We pull on it with the hope that once you do that, the obstruction of the tip of the catheter will follow the blood flow and go into the syringe. You clear the line that way, and you will know that it's out because you're going to have normal waveform again and have a new pressure with it. Okay? That's the first thing to do. That's the most safest thing to do. Okay? Now, if that doesn't work, then it can be that the catheter is rotated, meaning that it is jamming at the wall of the blood vessel like that. So you can rotate it. You take that catheter, you cannot do this. Okay? Wiggle a little bit. So that will get it out of the wall of the blood vessel. Okay? Now, if you've done that, and that didn't work, then the last thing you want to do, and the most dangerous thing that you want to do, is to flush the line. You draw up like a small normal saline inside the syringe, and then you hook it up here, and then you push it down. Okay? So now, the reason that we don't want to do that always, or do it as a last option, is if you have a blood clot distal to the tip of the catheter, once you flush, that liberates the clot, and then the clot can embolize. Okay? It follows the blood flow. If it ends up in your lungs, you have pulmonary embolism there. If it ends up in your brain, you're going to have stroke. It will stroke you out. If it blocks the artery that sends blood to the heart, to the myocardium, in the coronary artery, you're going to have a heart attack. Okay? So we have to be very careful. We have to try these other things before we try to flush. Okay? Flushing is a little more dangerous than rotating the catheter or aspirating the syringe. In most cases, nurses will aspirate the syringe, even several times before they try to flush it. Any questions about that? So the next thing that will affect the integrity or the accuracy of the pressure being measured will be the integrity of the transducer. Okay? Do you have it before you start measuring your pressure? Do you have it at 0 point? In other words, sometimes the transducer can sense the atmospheric pressure. You know, like it's like this. So the atmospheric pressure is down this way. So it's feeling that as well. Okay? So before we start measuring the patient's pressure, we have to make sure that the pressure in here is 0. Okay? Basically what we do is we open it up like that, and then we allow the transducer to equilibrate with the atmospheric pressure. If you go in the ICU, sometimes you hear that noise, boom, 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 boom. Okay, maybe that's the nurse trying to zero out the transducer. Okay, so once you've done that, you put it back. Okay. So we have to be at the zero level, because if it's already sensing like 20 of pressure, and you hook it up to the patient, well, the patient's pressure will be 20 more. So that's not the patient. Okay. The next thing is we have to make sure that the transducer is at the level of the heart. Okay, and I'll tell you why in a minute. Okay, because this whole thing here stands on the IV pole. Okay, so we want to make sure that here the patient is lying down over there, and the transducer is at the level of the heart. We're hanging it. We don't want it to be way above. We don't want it to be way below. It will be at the level of the heart. Okay? And then the next thing is calibration. Okay? You have to calibrate your transducer. Okay, now calibration is nothing but you are taking a known value and you are putting it into something, and then you are expecting that thing to read back what you put in. Like, if I want to test my transducer to see whether it's measuring accurately, I can plunge in a pressure of 5 in here, and then see whether it reads 5. Okay, if it does, well, it's calibrated. If it doesn't, then somehow you're going to have to tweak it and make sure that it reads 5. That's calibration. Okay. So here's zeroing. Okay. Making sure that you are measuring the pressure from 0 reference points. Okay, there's no more pressure being sensed by the transducer when you hook it up to the patient. So it says that the transducer monitor must be given a 0 reference point. Establishment of 0 reference point is done at setup. Like once you finish putting in the catheter, you're going to set this up, you hook it up. Before you start measuring, you're going to make sure that you have it at 0 point, okay, by allowing the transducer to equilibrate with the atmospheric pressure. Okay? During the beginning of the shift, nurses do that a lot. Before they start their shift, they will zero the transducer. Anytime the validity of the pressure values measured is in question. So you're looking at the patient's blood pressure, you say, oh, okay, that cannot be him or her. I mean, he was just 140 over 90 a while ago. How come is he 90 over 60 now? Okay. Well, I'm going to zero my transducer and then hook it back up and see what I got. Okay. Okay, so by zeroing, you are eliminating the effect of the atmospheric pressure, acting on the transducer that way. Okay? The lower you have it, the more atmospheric pressure that is pushing on. And how do you fix that? You open it up so that the pressure in there can equilibrate with that of the atmospheric pressure. There's another thing there, another pressure there. Hydrostatic pressure, we talked about that yesterday. Well, hydrostatic pressure is the pressure exerted by fluid inside a space. So you have this fluid in here now, the normal saline coming down. You have hydrostatic pressure in there. Okay? So now, let's say that my transducer is down here. All that pressure created by the fluid is pushing on the transducer. See there? So that's why you have to make sure it's at the level of the heart. Well, if I have it this way, the transducer is way up here, then all the pressure is coming down this way. The transducer is not feeling much. It's going away from the transducer as well. So, hemodynamic pressures are inversely related to the position of the transducer. We have to make sure it's at the level of the heart. Okay, in fact, sometimes nurses will have like a stick they put it on the patient's bed, and then they line it up with the transducer to make sure that it's at the same level. The right heart, specifically the right heart. Okay? Now, if the transducer is placed way below the patient, okay, then the hemodynamic pressures measured will be higher than normal, because you have the fluid putting pressure to the transducer like that. If the transducer is placed way above the patient's heart, then the hemodynamic pressures measured will be lower than normal because the fluid is going away from it. Any questions about that? So the hemodynamic pressures measured are inversely related to the position of the transducer. Okay. If the transducer is placed way low, the hemodynamic pressures will be reading higher than normal because all the fluid is putting pressure on the transducer. If you put it up while the fluid is going away from it, you will be measuring less pressure. So the best thing is to put it at the level of the heart. Okay? So here, so we talked about all of this here, and how you remove the hydrostatic pressure. It's just by leveling. And then we talked about the calibration. Okay, you calibrate it. If the transducer is still good, well, it has to be able to measure whatever pressure that I put in here. I put in there. Bring it back to me. Any questions about the fluid field system? You must hook one up to any intravascular catheter if you're going to monitor blood pressures. Then two components of the fluid field system. Anybody?
The flush.
The bag? The flush
I
system,
said the flush,
right?
yeah, the flush system.
Yeah. And then what else? Yeah, the catheter. Okay, it's another one. What would be, that's what I should say, what would be the first action to take if the fluid fuel system became obstructed? Aspirate, very good. That's the simplest thing to do, because once you aspirate, hopefully you can get that obstruction out. Okay? What would be the last action to take if the fluid fuel system became obstructed? We're going to flush. And then it's more dangerous to do that. Okay, try these other two things first, and then you can flush. Hopefully, it's not a blood clot at the tip of it. Because once you turn it loose, then you will follow the blood flow and go somewhere. Maybe it will cause problem. How do measures hemodynamic pressures relate to the level of the transducer with the right heart? Again, if the transducer is placed way above the heart, that reduces hydrostatic pressure, okay? And the hemodynamic pressure measured will be lower, okay? If you place it way below the patient, okay, well, all the fluid is putting pressure on the transducer, therefore the hemodynamic pressures will be falsely high. So what we need to do is to make sure that the transducer is placed at the level of the right heart. That will eliminate that problem. Okay? All right, so I wanted to go to 9:30.